Hello, good evening, everyone. My name is Annie Benzie. I'm chair of the Fellow Subcommittee for Complex GI Surgery Fellowships Working Group, or SSAT. And thank you all for joining us. Hope everyone's staying warm now that it's through December. We have a great talk tonight. Definitely think we're going to get into some good discussion. So please contribute. And I am very honored and thankful to introduce Dr. Stephen Bruns as our moderator for this evening. Dr. Bruns is also a member of SSAT, as well as the clinical assistant professor of surgery at University of Oklahoma College of Medicine, and the acting deputy chief of staff at the U.S. Department of Veterans Affairs in Oklahoma City as well. So without further ado, Dr. Bruns, if you wouldn't mind just starting us off.
Yeah, thank you so much, Annie, and excited to be here. The SSAT does such a great job educationally, and we're honored, I think, today for everyone to be here and participate, as you mentioned. I think that this is an interactive session, so I think that welcome everybody's comments, and our presenter, Maya, will be happy, I'm sure, to field those questions, as will I, and help to facilitate that active discussion. Grateful for a very pertinent topic. We were talking a little bit earlier. This is a topic that needs a lot of attention. We certainly see it in the middle of the night. So I'm excited to share the slides and my slides, and then really have a great discussion, I think, about some of the complexities of this particular disorder. So turn it back to Annie and Maya.
Perfect. Maya, you can go ahead.
Hi, everyone. I'm Maya Elguayal. I'm the Complex GI Fellow here at Franciscan in Tacoma, Washington. My program director is Dr. Cho, and I'll be discussing perforated peptic ulcers. I'll be touching on a lot of different aspects of the disease process and its management. And I guess the reason I chose this topic was that I actually enjoy operating on these, and I realized that I've only done one lap omental or gram patch, and I've done mostly open cases, so I wanted to learn more about the surgical management of the disease. So I'll be starting with introduction and background, and then just basic management. I'll have a case to discuss, and then I'll be speaking about surgical, both non-operative and surgical management of the disease, as well as endoscopy. So specifically, I wanted to focus on perforation, but the most common cause of perforation is peptic ulcer disease, and worldwide, H. pylori and NSAIDs are the highest risk factors, in addition to smoking. We are seeing a big incidence in patients who use like stimulants like cocaine and meth as well. Peptic ulcer disease is quite common here in the US. I read about sources citing that 14 million, 15 million people a year are diagnosed with it. It's pretty common. And then perforation can occur in 5% of PUD patients. The range of mortality really depends on the patient's comorbidities, and age is also a huge factor. But I saw data citing even up to 50% in some situations, but generally it's somewhere between 5 and 15, and then 25% for sicker patients. And then I just wanted to list all the potential etiologies of perforation. I won't be touching on marginal ulcers and perforated marginal ulcers. A different fellow will be discussing that at a different time. So I wanted to mention this study here by Idris et al. That used a national database here in the US, looking at how mortality really depended on the patient's age. And there is a huge difference between 65-year-olds and older as compared to younger patients in terms of mortality. So just something to keep in mind. And then regarding ulcer pathophys, an ulcer is defined as injury beyond the submucosa, and then perforation obviously is full thickness injury. And then peptic ulcer disease most commonly presents in terms of in the emergent setting as bleeding. It's 6 times more commonly. It presents more commonly as bleeding 6 times more so than does perforation. You can also get gastric outlet obstruction from peptic ulcer. This is a map showing the prevalence of peptic ulcer disease in the world, and I just wanted to highlight how high of a prevalence we do have in our country, even when compared to Canada and Western Europe. So I just thought it was interesting. And it's been found that in developing countries, the higher rate of peptic ulcer disease is associated with a higher rate of H. pylori infection. So regarding H. pylori, 10 to 15% of patients with H. pylori potentially develop an ulcer. And then here in the US, there was a study looking at outpatient scopes, and they found that 14% of gastric ulcers were H. pylori positive and 21% of duodenal ulcers were H. pylori positive. So it's both gastric and duodenal. And then there are certain patient populations here in the US that have a higher association with peptic ulcer disease. Overall, they did note a decrease in peptic ulcer disease over time in the study time period. I just wanted to quickly overview ulcer locations. This is like a board/app site topic. So type 1 lesser curve is the most common location of peptic ulcer disease, and then type 2, which is simultaneous gastric and duodenal ulcers, is the second most common type. A giant ulcer in most of the literature was defined as an ulcer that was greater than 2 centimeters in size. And then there's data that's kind of older. It was hard to find data that was more current about the incidence of, the diagnosis of malignancy during a perforated ulcer, but about 10 to 16% of gastric perforations were related to cancer. And then in terms of duodenal ulcers, anterior ones are more likely to perforate, and posterior duodenal ulcers are more likely to bleed. And obviously, you can have Meckel's with gastric mucosa causing a perforation, although ectopic pancreatic tissue can also cause perforation. And then there are esophageal ulcers are also considered peptic ulcers. And it's just some summarizing diagram. I like pictures, so you'll see a lot of pictures on this PowerPoint. Can somebody name this phenomenon?
One of the fellows who would like to volunteer. Dr. Ewing. Oh, thank you, Vladimir. Kissing ulcer.
Nice. So a kissing ulcer is basically when you have both anterior and posterior ulcers that occur simultaneously. So it's a good reminder to always check the posterior wall of an anterior ulcer when you're in the operating room or scoping, obviously. This was a really good resource for me. The World Journal of Emergency Surgery published guidelines in 2020 on how to manage perforated and bleeding ulcers, and that's something I refer to a lot in this presentation. So this is just for trainees or whoever, if they wanted to look at this resource. I thought this was the most comprehensive one. So initial medical management, IV antibiotics, broad spectrum, NPO, NG tube. I guess we can talk about more if we want to, but obviously you don't want exacerbated perforation by, pushing onto a gastric ulcer, but definitely for duodenal ulcers, and if there's dilated stomach or evidence of obstruction of the stomach. And then BI dosing of IV PPIs is indicated. Antifungal is actually not standard anymore. So I know, well, at least in my training, certain attendings wanted us to order antifungals for every ulcer and perforated ulcer patient, but it's actually not recommended for all patients. And then H. pylori should be tested and confirmed before starting to treat empirically. And I just wanted to bring this slide up because it shows that the stool antigen tests as well as the stool PCR tests are actually more accurate than a histological or biopsy finding of H. pylori. So you don't actually have to biopsy to diagnose H. pylori. The stool test is sufficient. I wanted to move on to this case study that we had here at Franciscan Health. It's about an 89-year-old gentleman with significant cardiovascular comorbidities, PE on Eliquis, CHF. He had a CABG in the past and CKD3. Patient was not a great historian. He was in septic shock when he presented with systolics as low as the 80s. He was responsive to IV fluids, and his pressures improved to the 110s, 120s with fluids. His white count was actually normal. He did have a slight left shift. He had an AKI. He's chronic anemia, and he had a UA consistent with UTI. He would describe some right lower abdominal pain worse with PO intake. He denied nausea and emesis. He denied GI bleeding. He did report bleeding or blood in his urine. This is his CT scan here. So I just wanted to emphasize how dilated his stomach is up to his pylorus. And I think you could argue that there's maybe a slight defect in his duodenum, but it's not extremely obvious. He did not have free air. He had a little bit of free fluid, but not a significant amount. And he was noted to have a mass in his pelvis on his CT scan. So the diagnosis is not very clear based on what we have so far. Because he continued to complain about
got a hand up there, Maya. Dr. Bruns wants to say something.
Yeah.
Yeah, I just want to make two quick comments. Number one, don't be fooled by the normal white count. It's a big torpedo for a lot of different acute scenarios. Obviously, a shift helps you. And then clearly this patient was obviously quite ill, so that was an easy one, but don't be fooled by the normal white blood cell count. A second comment I would like to make is relative to the large size of the stomach. Even if these patients don't overtly sound obstructed, so they don't come in and say I've had early satiety or whatever, often after repairs, it will take them a while to really fully open up and recover gastric function. So I just want to make those two comments, particularly based on the imaging and the labs.
Also, internally, I've noticed a lot of elderly patients will be septic with a normal white count. So I've seen that. So patient underwent upper endoscopy for this persistent abdominal pain. They couldn't really find a good diagnosis for, and there's a concern for gastric outlet obstruction based on the scan we just looked at. And during a scope, they did find a 2-centimeter perforation at D1 anteriorly. And the GI doc could actually see the liver when he put his scope through. And weirdly enough, patient also had necrotic esophageal mucosa for about spanning 20 centimeters. And then before the scope, patient did not have peritonitis, but after scope definitely developed peritonitis. So he was taken to the operating room for an open modified gram patch repair and washout. An NG and JP were placed during the operation. Eventually, the path did not show malignancy. H. pylori was negative. We did culture the peritoneal fluid, and it was positive for fungal growth. And then because of this necrotic esophageal mucosa, patient got a stent with thoracic surgery at the same time.
So I just have a question too. So if he didn't develop peritonitis and they didn't do this EGD, how would you have managed this patient? Would you do something differently?
I would say he could have been managed endoscopically, which I'll touch on later on. But I think if he remained stable and he did not develop peritonitis, then I think it could have been managed endoscopically.
Yeah, I think this is another good thing about like compression too, because you obviously like decompression, sorry. Like you obviously know if there's something going on there, right? But you don't have the imaging to prove it. Your patient's fluid responsive, which is good, but he's also 89 years old and he has a lot of other things going on, right? So in training, like what we did in these situations is sometimes we just do like a very early repeat CT with PO only, like almost have them drink it and then lay down on the CAT scan table. And especially patients that have esophageal perforations too, because I mean, this guy does have necrosis. That can really be a benefit too, because you may have, like you said, two things going on, right? You can have esophageal ulceration, Boerhaave, and then you can have like a process further down too. So you never want to miss anything. And I think covering your bases with a contrasted study is a really easy way to handle that. And then, of course, yeah. So, do we peel off nature's gram patch, which is always the question that we have, right, by going in there. So, I agree with all of the above. Thank you. You can keep going.
I think for him, it would have been difficult to give an oral contrast just based on how distended. But obviously, if you decompress him first and then give him contrast through the NG, yeah. So I wanted to discuss when to do non-operative management, which is, thank you for that segue, Dr. Benzi. If you do have water-soluble imaging to confirm that there's no frank leak into the peritoneal cavity, you can continue with non-op management. The other thing is you might have a perforation, but there's not, either it's contained or it's an older perforation. You might have minimal free air, like specks of free air as opposed to frank, a large amount of free air. And then when patients are not peritonitic and stable after resuscitation, it's possible to manage non-operatively. So I did find a few. Oh, sorry. Go ahead.
Well, I was just going to comment. You know, I think we've all seen these cases where we go in operatively to remove the omental patch over the hole and then replace the omental patch. And so philosophically, you think, well, why are we even here? And the reality is because the omental patch doesn't do enough, right? And so when we think of non-operative management, I think it's really important to recognize that even though it may look sealed when we're there, or we're reassured by whatever, always be mindful that ultimately suture repair or some of our other sort of non-operative modalities may be much more effective. And non-operative repair doesn't always mean non-treating, right? We have these other tools in our toolbox.
The other thing that the literature showed is that non-op management, it has a high failure rate in elderly people. Specifically, one study found that it failed in patients older than 70 years old. And then there are multiple studies looking at how delay in surgery increases mortality significantly. So it's something to really weigh your options. Oops, sorry. Wanted to just mention open strategies for perforated gastric ulcers. First, you have to decide, does the patient need a damage control surgery? Can you do a primary repair? Do you need to leave the abdomen closed? Can you just wash out and leave drains? Generally speaking, if the patient is unstable, you need to do an open rather than a minimally invasive operation. At least that's the standard at this time. And then I just wanted to mention different repairs for different ulcers at different locations. Generally speaking, for smaller gastric ulcers or duodenal ulcers, a patch, with a mental patch with primary repair are indicated. Just remember that the leak rate is higher for ulcers, the giant ulcers that are greater than 2 centimeters. And if they are larger, you can consider doing a jejunal serosal patch. Or if they're in an area that's difficult to resect, you can also consider doing a jejunal serosal patch. If they're at the greater curve, somewhere easy to access, then a simple wedge is great because you can also, you'll have tissue biopsy at the same time. And then for distal gastric ulcers, you can consider a distal gastrectomy with Bill Roth too. So I just wanted to kind of highlight the fact that the original gram patch was actually a free floating patch of omentum, not a pedicle. And it was used just as a plug. And then sorry if I'm pronouncing it incorrectly, Sealand-Jones repair was a pedicled omental flap to plug the hole. And then modified gram, which is what I've used in the operating room, is the primary repair with a pedicled flap. And on the right is just an image of the Billroth 2 reconstruction after distal gastrectomy. So regarding biopsy, obviously, if you're doing a wedge resection, it's not something, or a distal gastrectomy, it's something you don't really need to think about. But if you're concerned, if there's a larger or more complex gastric ulcer, you should definitely think about biopsying the tissue. There is a very, very, very small association of malignancy with duodenal perforation, so it's not really indicated for perforated ulcers unless obviously the patient has a history of some sort of duodenal cancer. If you're unable to biopsy, say the tissue is very friable, patient is not doing well, you're going to make a tiny hole much larger in a place that's inconvenient. You can always consider just biopsying in the future on a future scope. And then there is an interesting idea of doing a frozen section if you're able to in the operating room, because then you can, rather than just doing a patch, you might have to do an oncologic resection if the patient is stable. And then you should always sample fluid, the peritoneal fluid, when you're in the operating room. Regarding open duodenal repairs, just remember you have to preserve the ampulla of Vater and D2, so you can only really remove D1, D2 proximal to that if those are the areas of concern. And in the literature, I found that the jejunal serosal patch is very commonly used for duodenal ulcers. Billroth 2 can also be used, and then you can also do a Roux-en-Y DJ. And it's actually, I found it more commonly in trauma literature for traumatic perfs, but pyloric exclusion with GJ, I've done it one time in trauma, is another open strategy. There was a study looking at tube duodenostomy in Vietnam. In the World General Surgery Guidelines, it's considered a last resort strategy because, you're just creating a fistula essentially, and it'll probably be high output. And then I don't really know much about the sutureless strategy using glue or other hemostatic agents, but it's definitely described in the literature.
So a quick question for the audience. Does anyone here do jejunal serosal patches? Like, I know it's something we always talk about, but I've never done one. I've never seen one. And my concern as well is, you can basically create a fistula at that site, right? Which then is kind of like a never ending loop. So I always worry that you're going to have almost like a marginal ulceration as well due to blood supply. So I'm just wondering if anyone has had any experience with those.
Yeah, Annie Bruns here. I've done it for trauma, just like Maya described. I've not done it for peptic ulcer disease, but have done a thal patch for trauma with good results.
Apparently, it's the recommended strategy for posterior duodenal perforations.
Interesting. Well, yeah, I actually had a patient that had like a kissing ulcer kind of phenomenon. So like when we went in, there was like a very obvious anterior hole. It was just freely like leaking bile. So we ended up doing a mental patch. And then I noticed, this is laparoscopic, like the lesser sac was like bulging, and then kind of like just opened it a little bit, and there's actually bile back there. And the posterior ulcer was huge, like absolutely huge. So I always think that too. I always get worried because I try to approach these laparoscopically because I think the patients do better, right? Especially if they have high risk factors, like cirrhotics, for example. Tends to be really tricky to manage those patients with the patch, right? So that's just like something in my mind that is not going to be ever written in any textbook, right? But always open the lesser sac when I do these cases laparoscopically, because I have that experience now of almost missing that huge posterior defect too. So it's just an interesting tidbit, right?
Thank you, Dr. Cho, for reminding me of include that. So.
Yeah, during perfect. Yeah.
Sorry, what?
No, just in the chat too. So everyone's saying like, yeah, they're trying to do for basically trauma.
I have trouble like looking at my slides and then paying attention to the chat. So you got me.
Yeah, actually, go for it. Yeah, I got you. Don't worry. Yeah, and even too, it's like when you have a little bit of that terminal ileum that comes over to your perforated diverticulitis patient. I always think about those patients too, because there's always like you could put a couple stitches in that and kind of hope for the best. But I've actually had to resect small bowel too in those cases. Because the body's very smart, but we think we're smarter, right? So we go in there and try to do some damage control. It's just interesting. Cool. Go ahead. Oh, yeah, here you go. Technical slide.
Yeah, these are just images of how to do these operations for the trainees who are not as comfortable. So pyloric exclusion, you literally make an anterior incision and bring up the pylorus and you're suturing it closed, and then you generally do a DJ. I'm sorry, a GJ. I think this is from trauma literature, so I think they were like doing a serosal patch and exclusion at the same time. And then you should obviously do a GJ to decompress. And then this is a tube duodenostomy from the Vietnamese paper. Again, it's the last resort, but I thought it was interesting. I never thought about it before. So I don't know, has anyone ever had to do this before?
Yeah, so I guess maybe my patient selection has been more challenging than some, and then I didn't choose them, they chose me, but I have done duodenostomy and I have done pyloric exclusion. And I put in the chat, and I would just emphasize that I very much view these as damage control, bailout sort of procedures. These are not my preferential procedures. I actually had really good success with Gram Patch, and I'm a big fan of that. And that can be done, as you know, under any circumstances, whether that's laparoscopic, open, or robotically.
I've done pyloric exclusions too, and just interesting the way the stomach is designed, it will essentially ignore a jejunostomy unless you exclude the pylorus. So the whole purpose of excluding that pylorus is to allow diversion of the flow, to allow the ulcer or the damaged area to heal. But the jejunostomy essentially is there. The jejunostomy itself won't do the trick. You have to actually give the stomach a reason to use the jejunostomy, because its entire design peristalsis wise will just ignore a jejunostomy if you're doing a vacuum.
And you use the TA stapler for that? Does anyone ever do that? Or you use the TA stapler to go across prepyloric, and then it's supposed to like recanalize instead of opening and like sewing like in that picture?
Yeah, both. So I used a TA and I did see it recanalize. It was with one of our anesthesiologist family members, actually. So very close follow up for me, and she did well. But yeah, so I used TA and then she recanalized. It was great.
Cool.
For the exclusion? Okay. I'm sorry, was there anything else? All right. And then I'm just to mention bleeding peptic ulcer disease. Usually this can be taken care of endoscopically, and I've never had to operate on a bleeding ulcer in my training, but you would do the 3-point stitch to ligate the GDA. Has anyone had to do an operative?
I did. This is Molly Russo from Orlando. I did one when I was a 4th-year resident on a 21-year-old. And we worked this kid up for everything because we couldn't believe how he was so young and, as far as we could tell, relatively healthy. But it was kind of insane. I trained at a level 1 trauma center, and I can say that I've never seen so much blood. Like, I walked into the ICU when they called us, and it was like from a movie. There was blood all over the bed, all over the floor. It was crazy. But he lived. He did really well.
Did that patient fail other non-operative management techniques, I assume, embolization, things of that nature?
There, if I remember correctly, I think he either failed just one maneuver and he decompensated so quickly, like they were MTPing him almost immediately, or he didn't even get to that point because of how unstable he was. Um, I can't remember now if they sent him to IR. I think they did send him to IR once and it did fail, but he was in the hospital less than 24 hours before we took him to the OR. Oh, sorry. Did you hear me?
Yeah, we heard you. Yeah,
Okay.
lots of blood.
And then just to bring up, generational differences in training. I've never done a vagotomy, but there was a study looking at the trends in entrectomy, vagotomy over time since with the introduction of PPI and H2 blockers, and they found that like less graduating chief residents had less than one of those operations in their case log. So I don't know if you wanted to discuss those differences based on your training experience.
I think Dr. Cho, I think we call that senior now, not old, senior attending. But yeah, would you mind giving us a little historical background on what happened before we had PPIs? Because I think that's important. Anyone that would?
Are you asking Maya or one of us old guys?
Yeah, senior, Dr. Cho.
Oh yeah, so peptic ulcer disease that was an every week type operation back in the day, back in the 70s, and with the onset first of Tagamet in 1978 or so, that fell off a cliff. So now you have people, as Maya's data show, with fewer vagotomies, and what's even more rare is now the highly selective vagotomy than they have Whipples. So it's become a almost a referral base or a tertiary referral type operation now.
Yeah, I couldn't agree more. I think, we definitely see far less of those peptic ulcer disease operations, the definitive operations. Oftentimes, though, where it's the middle of the night and we're in the situations that were described, it's either exsanguinating bleeding that's failed or not an option to go to IR, or it's the free perforation. And how do we manage this big ulcer in the antrum, and how do we fix that problem? And I think, one thing that I was thinking of, both in terms of when I took my oral boards and as I prepared for today, I think it's always a great plan to have that plan in place of what am I going to do when there's a big ulcer that I can't really close or excise. What am I going to do when the patient's unstable? What are my bailout moves? And I think Maya did a great job of talking about some of these damage control moves that very much are utilized in some of these really sick patients, because we definitely see them in that setting.
It's my impression. I know there's evidence that PPIs are certainly more effective than H2 blockers, but it's my recollection that the big cliff that ulcer disease fell off is when H2 blockers came on board. That was just a night and day difference between this is a this was a procedure that you basically couldn't get away from in residency, becoming an index case.
PPI are better at managing bleeding as well, typically.
Okay, Maya.
Now for the minimally invasive repairs. So those are in hemodynamically stable patients, at least, that's kind of the current guidelines. If they're unstable, you should do an open operation. And I was trying to find different data because I was reading, obviously the Nordics, the Scandinavians have a ton of literature on peptic ulcer disease and perforated peptic ulcer disease. And then there's a great amount of literature from India, China, South Korea. But I noticed that the use of laparoscopy was a lot lower in the US. So this paper by Wright et al. Was looking at the use of lap first open repair. And this was in the early 2000s, and it was about like 2.7%. And then in Denmark, in this paper, they were looking at the national database, and that was between the 2000s to 2000 teens, and 60% were laparoscopic repairs or attempted lap converted to open. And then the other papers, I mean, it's not an exact comparison because they're either looking at one university hospital, or in the case of the South Korean article, they looked at 5 university hospitals, but the use of laparoscopy is pretty high, I would say, in other countries. And this comes from a French paper by Rebivo in 2016. This is more for the trainees or whoever is interested in doing laparoscopic repairs, but they recommend a cut down at the umbilicus using at least 3 ports, potentially a 5th port if you need a liver retractor, and then standing between the patient legs, putting patient in reverse Trendelenburg. So if you wanted a resource for that, I'll have all my articles cited at the end. And this is a video again for whoever. I love watching surgical videos, so for whoever wanted to watch and see. I don't think we have time for that during this talk. Then I looked at different papers comparing lap and open repair. This is a meta-analysis looking at only randomized controlled trials. These are global articles, not just US based. They did show that laparoscopic repair did have less morbidity, less wound infection, and shorter length of stay, and that's adjusting for patient comorbidities and other demographics. As you would, assume that, obviously laparoscopic cases are occurring in healthier, less sick patients, but they actually adjusted for that, and the results were statistically significant. There is no difference in leak rate and intra-abdominal abscess. There's another study in the UK. They have their own national database, and they did a retrospective study that was propensity matched. And they also showed the very slight decrease in mortality between lap and open. I don't know if 1.2% is a huge difference, but also it's not statistically significant. The p-value is 0.23. And
by the way, on this topic, if you're imaging, if you're running a contrast study, and most of us probably do run a contrast test before we start feeding them after a perfect repair, and you do see a leak, you don't have to reoperate on that. A large majority of those will seal over or given more time, and you can just keep them on intravenous, or hopefully if you put a feeding tube in, distally feeding rather than going back in and trying to reoperate on a place you just reoperated on.
Yeah, I think it's a good point. I think some of it depends on what degree of leak they have and what the other circumstances are. But I agree, trying to dive back into a reoperative abdomen can be really challenging. And I think, from my perspective, in terms of the tools that you use to fix the ulcer, I kind of view open, laparoscopic, and robot as just different tools in our toolbox. And so, if you're particularly facile with the robot, your team is particularly facile, can get there and do what you need to do, whether that's laparoscopic, open, or robotics. I think it really comes down to what's the patient like, and what is your team like, and what are your skills like, and that helps you make the decision of what's the most appropriate setting.
And this is another study looking at cost efficiency, basically in the US, looking at the nationwide inpatient sample in the US. Basically, although lap is more expensive in the OR over time with length of stay and lower mortality, there are less total charges in the lap group, and this was significant. I try to find articles comparing robotic cases to open and lap, but I didn't find any. But I did find another cool video, which, again, if you enjoy watching videos like I do, here it is. And here, the interesting part in this video is, like, as he kept removing the fibrinous tissue, he could really see like where the ulcer was. I think for me, sometimes the difficulty with the robot is I get tunnel vision. And then also he used the same V-lock to do the primary repair and then the omentopexy. So.
When you say that, you mean he tied the repair and then he left the tails long and they just put the pedicle in between there and retie?
You don't need to tie with the barb suture.
Oh, okay. Not
Yeah.
retie, but then reapproximate them using the tails, basically.
So he just had a really long suture and he ran it one way, but the omentum ran it the other way.
I see. Okay, thanks.
Mm-hmm.
I think one of the most important principles of this is just that you repair it, get a good repair the first time. So it's just one of those situations where converting to an open procedure is not at all a failure. I did one of these robotically or attempted robotically, but the location was sort of a little bit posterior on the lesser curve, so a really difficult location. And I just couldn't get great visualization of the entire, like the posterior edge of it. So, in that case, the priority is getting a really good repair so you don't end up having to go back into a reoperative field. So I went ahead and opened and he did fine. So it wasn't a failure. We tried.
Yeah, Dr. Everett, I couldn't agree more. I think that's a great comment. And when I do these, I do like to do a little bit of a Coker maneuver or sometimes a generous Coker maneuver. And if you're struggling laparoscopically or robotically to do that, sometimes that does make the repair more difficult.
That's great advice. Thank you.
100%. And if you're tying your gram patch on top of this, my pearl would be not to over tie, not to tie it too tight and strangle your pedicle omental flapper. You're basically just doing a free flap at that point.
And I just wanted to touch on endoscopic interventions. I've personally never done these, but they seem pretty cool to me. They're generally used for containing leaks, smaller perforations, and in stable patients. So they're metal stents, covered metal stents that you can place clips over the scope or through the scope. Their evacs can even be used for esophageal perforations or ulcers. And then there's this really cool article by Kanakis and Irani. They describe through the scope suturing. And this is only one of the images, but it's like a pretty sizable perforation that they were able to suture closed endoscopically. And then this is just I'm not sure if it really changes, if it would really change our management, but there's this article from Sweden where it was an RCT and they compared a randomized controlled trial and they compared laparoscopic lavage with stenting versus just straight lap repair. So I don't really see the point in like taking the patient in the operating room to do the lap without the repair. But anyway, they showed the OR time was shorter for the stent group, and otherwise there's no statistical significance in complication or outcomes. Just something interesting.
Dr. Russo, you mentioned you had experience with some of these endoscopic management. Do you mind just commenting on it?
Sure. Yeah, our MIS group did a lot of their own endoscopic maneuvers, not even our GI guys. And to be honest, a lot of my experience was with bariatric patients. So whether it was leaks after a sleeve or ulcers after a Roux-en-Y. But we did a number of over the scope clips as well as endoscopic suturing. And it was pretty neat. And most patients did really well.
Excellent. And then you come back to take out the stent too. That's always the question that I have, right? It's like, how long do you leave it in? Because they do erode, as I found out. Had that unfortunate experience one night. So how long were you guys routinely leaving them for? Or when do you go back and check, I guess, is the better question. Do you remember?
The stents, honestly, pretty frequently. I want to say every maybe 1 to 2 weeks, but I don't think we ever left anybody longer than 2 weeks. And sometimes it was a stent exchange, but that was a real fear with our patients was certainly the erosion or the incorporation. So certainly no longer than 2 weeks.
And then what do you do about the peritonitis, like if you have collections in those patients? Is that like IR, or did you go back laparoscopically like this paper talked about?
So maybe we had one or two, but I think in that instance, if we had a patient that actually had a fluid collection, we probably would have just taken them for a full-on laparoscopic procedure. But I would imagine, I think if it was something that had developed afterwards, we probably would have sent them to IR. But most of our patients with these issues, they did not have like big fluid collections, or we would have just taken them for a lap repair.
Thank you. Go ahead, Maya.
It was just from a Swedish article. It was just interesting because it seems like they use the endoscopic approach for ulcers up to 3 centimeters, which I just thought was interesting. Then I wanted to talk about leak tests just because I think ICG is really cool. And I know in the bariatric literature, ICG is used a lot. It can be used intraluminally to look for leaks during bariatric surgery. So I was just thinking we could potentially use ICG after we repair an ulcer to see if there's a leak. And I got this dilution amount from the Boehringer Labs. They did not pay me to put that up, but it's not standard to do a leak test after repair in this setting. But obviously, you can do it with air, water, and potentially ICG. And there's some articles that are starting to look at whether we need to use NG tubes or drains post-operatively. Neither of these are in the US, but one small study showed there was no difference in, that not putting in NG actually decreased the length of stay and fast forwarded the advancement of diet in patients. And then another study looked at, not leaving surgical drain similarly decreased length of stay and advanced their diet a little bit more quickly. And there was no statistically significant difference in leak rate in this second article. I don't know if anyone wanted to discuss. I generally leave drains in these cases. I don't know if anyone had something to comment on that.
I am pro NG tube out usually the first day and very much anti drain.
What about
drains or fistulas waiting to happen in almost every case?
What about studying these patients? Do you study them before you feed them?
I don't.
Oh. I personally would study them if I had a clinical suspicion or concern.
Sorry, just to clarify, so you generally remove the NG tube post-op day 1, but don't feed them for a certain amount of time?
Thanks for that question, Dr. Hubbard. It's a gestalt, kind of thing for me. But my habit has been I have anesthesia, place the NG tube if there's not one there already, leave it in, and I try to get it out as quickly as possible. I have had the great fortune of never having an NG tube, but having interacted with them my entire life, the misery for my poor patients, I just want to help them. So what I typically do is pull it day 1, and then based on their clinical progress, feed them or not feed them, but I don't study them.
Right.
And you never place drains ever
Well, there's never for me, but I tend to agree with Dr. Cho. I think it's just like putting it next to a bowel anastomosis or anything else. I just think that it's probably treating me more than it's treating the patient, and so I just tend not to leave them.
I tend to study patients before feeding them, but mainly because I want to see what the gastric outlet looks like after all my manipulation. So I'm not sure that it's necessary clinically because we know there's a very high false negative rate for studying even esophageal leaks after a gastric bypass. It's a very high false negative rate for just using contrast. And that even if you do have a subclinical leak that doesn't, like we just talked about, doesn't necessarily mean you have to go back anyway. So there's not a lot to gain from that from a leak standpoint, but from seeing what my manipulation did, whether it's a Graham patch or foul patch or whatever to the gastric outlet to me is valuable, if only to compare 3 months later down the line when they're having trouble.
Yeah, I think that's a great comment, and I would point back to our example case with this massively distended stomach. That patient may, quote, tolerate PO, end quote, but that stomach is not going to empty well. So I have definitely seen those patients that get fed early in that situation, big distended stomach, kind of chronic gastric outlet obstruction, even if it's not complete. And they'll just fill their stomach full of their clear liquids or whatever you're giving them. And so I think those studies are helpful in that setting.
But just to be clear for all the trainees and people taking their boards, like err on the side of caution too, because technically that is the textbook answer is still to drain it in G-tube, just so you know. And then when you become an adult like Dr. Burns and Dr. Cho, and you have a lot under your belt, that you can do whatever you want. But the board answer is still drain them.
That's a good point. Thank you.
Perfect.
I'm taking oral boards in March, so I appreciate
That's why I said it. Yeah, because I'm like, yeah, people are going to remember this part, right? It's just interesting what we remember. And then you want to just wrap us up, Maya?
Yeah, these are just all my sources. If I don't know if we send these slides.
We don't, but so this is all recorded, right? So everyone will have them. If anyone would like any of the links, we're more than happy to email out the slides too. So you can just email Bev, our administrator, for this. Perfect. Thank you, everyone. Anyone else have any more questions? I know, Dr. Russo, your hand was up at one point again.
Yeah, I just I don't want to take up too much time, but my kind of going back, you made a brief point about considering doing the frozen section during these cases to potentially perform an oncologic resection, and I was just wondering what if you had more information on that, or if anybody had like a comment about doing, depending on whether ulcer is like a potentially total gastrectomy plus lymphadenectomy in somebody who you obviously weren't planning on doing that major procedure in, and who potentially, obviously, if they're unstable, you're not going to do that. But I was just kind of wondering if anyone had any thoughts.
Yeah, so just to make a quick comment, I've always biopsied. It's another thing, kind of like the gram patch that's already attached. You pull it off to put it back on. You're going to cut and make the hole bigger when you do a biopsy a lot of times. And so it's a little counterintuitive. Sometimes you're resecting the ulcer. Sometimes you're doing an antrectomy. But from a gastric ulcer standpoint, it needs to be done. I think that's somewhat controversial, but I think, again, as we're talking about the safe answer, I think that's the safe answer. Beyond that, I think your point is well taken in that a patient who presents acutely who's ill, that's going to be a really difficult decision about how much surgery will that patient tolerate. And so, again, kind of that judgment call at the time of surgery, listen, this patient's unstable. This is not the time to do a massive cancer operation. The patient's not going to tolerate it. Alternatively, that may be your best chance to get some nodes and to treat that problem. So definitely a judgment call at the time.
But if we're talking perforation, that's a T4 by definition, right? That's a through and through injury all the way through. So, I mean, for gastric cancer at least, I would think you're looking palliative at that point in terms of a functional result that isn't necessarily an oncological.
I think the question too, right, is like you put a patch in the middle of cancer, right? You're basically waiting for the cancer to grow back over the patch, right? So that's where it becomes challenging too. Like, I think it really depends on where it is, what it is, how extensive, right? If you have a whole stomach chock full of cancer is one thing versus, just the isolated mass or a gist or something like that, right? That's, easily taken care of too. And I unfortunately I've had the pleasure of doing that too, right? Where you just have this massive blowout of cancer and everything is a mess, and you just drain and basically wait for the cancer to grow back, and then try to treat it in some palliative radiation chemo way for as long as the patient can tolerate, or have that unfortunate discussion with them and their family too, which no one likes to do at 4 a.m. in the morning, but it's the reality of our life, right? Perfect. Dr. Bruns, if you wouldn't mind just wrapping us up.
Well, real quick, the major thing I'd do differently if I was worried about that would be to place a distal feeding tube. And we didn't talk about that a lot, but you can also place a transnasal, transgastric, transulcer jejunal tube, a long Dabuff, if you will, which is easier to deal with in the aftermath. But if I'm worried all about gastric function, about potential malignant diagnosis, you save yourself a lot of trouble and get some enteral access.
Very true. Good point. Nutrition
Yeah, I
is
agree. Great point, and that's something that certainly can be done, particularly if you have helpful anesthesia staff. It's very helpful. You can do it right at the time. I have put in a J tube on occasion for a massively dilated stomach, knowing that they're not going to resume, PO function easily. Just to wrap up, number one, honored to be here. I think Maya did an amazing job and really summarized what has become a relatively uncommon disorder. As Dr. Cho mentioned, this was a once, twice, 3 times a week operation not so long ago. And fortunately, through some of our medications, that's changed. But certainly you'll see it, it's out there, and you'll be asked about it, if nothing else. So again, from my perspective, for the trainees, I think it's great to have a plan in place for all these scenarios as you enter your call day or enter into your oral boards. I think Dr. Benzie did a great job of summarizing that as well. These are great topics to discuss, and look forward to the next opportunity to do it.
Excellent. Thank you all so much. Thank you so much for putting together a great presentation, Maya, and for being our moderator, Dr. Bruns. If you wouldn't mind all putting your cameras on for a second so we can take our Twitter picture and wish the happiest and healthiest of holidays as well as the new year to all of you and your family. Our next grand rounds are January 13th, and ulcer series continues. We're actually talking about marginal ulcers for that talk too. So a little bit of a different patient population, but I think still very valuable. And we actually have a second grand rounds, January 27th as well. So 2 in the month of January, and that's on the management of complex abdominal wall hernias. So just give me 1 second, do a nice screenshot. Everyone